Hello, everybody, and welcome to this, the first Buurtzorg Britain and Ireland webinar. We're using the Zoom webinar facility as a host for the first time, so what could possibly go wrong? Bear with us if anything does. It's the first in a series of webinars around the theme, Caring Places, Building Healthy Communities. And as many of you will know, we had a conference on that theme planned for the 21st of April 2020, which we've now rescheduled to the 20th of April 2021. But in the meantime, we're organizing a series of webinars, and it's fitting that the first is with the founder of Buurtzorg, Jos de Blok, Buurtzorg having inspired so many of us around the world in health and social care and well beyond. Buurtzorg started as one self-managed neighborhood team in 2007. It has 900 plus teams today, plus a number of new organizations founded since then, focused on mental health, domestic help, and other areas of care. Of course, just like every other health and social care provider, Covid-19 has been a big challenge for Buurtzorg. And today we're going to explore with Jos what Buurtzorg has learned in the last few weeks and what we in turn can learn from that. We started planning this webinar just a week ago, and since then around 200 have requested participation. We can only accommodate 100 on Zoom, so I'm sure you'll understand we've given priority to representatives of health and social care organizations. Online with us, we have representatives of many health and care organizations around England, Ireland, Scotland, and Wales, some politicians, some arm's length bodies, and more. We want it to be a discussion in which you can be open with your questions and you can be discreet. So we will be taking questions and answers in a written form. I'll be passing them on to Jos, and you can be anonymous about your questions if you want to. We're also joined from all over Europe and beyond. So hello to Austria, Belgium, France, Switzerland, Germany, and special welcomes to our friends in Canada and Australia. Staying up late down there, you're very welcome. A further 100 or so that we were not able to accommodate on Zoom are following our live stream on YouTube, and we'll also share a recording of this webinar as soon as we can. Our future webinars will be more participatory, but today we're keeping it simple so that we maximize your opportunity to hear from Jos and ask him questions. So you'll only see and hear Jos and myself, but as I say, you can put your questions in the questions and answer box if you click on that at the bottom of your Zoom screen, and my colleagues and I will follow that. So Jos, a very big welcome to you.
Thank you, Brandon.
And my first question is, how are you? How are you and yours? And how is everybody at Buurtzorg?
I'm fine, I'm healthy, and the people around me are healthy. And there is a lot of energy around us. This whole period, the last few months, we've been working very intense together and try to be connected with everything what's happening on a local level, but also on regional levels and also on national level, and to see what are the best things we can do to protect our patients, to protect our nurses, and also to learn from what we are doing. So that's, but we are fine, and we feel, I think, very strong in what we are doing. And I think we, in this special time, in this special period, we learned that this decentralized way of organizing has a lot of advantages.
Could you say a bit more about that? Because I know that for those who don't know, since you founded Buurtzorg in 2007 with one self-managed neighborhood care team, now grown to more than 900 teams, more than 10,000 nurses in those teams. And those teams are all self-managed, but also supported by regional coaches and by your back office, which has an important role too. Could you say anything about how the roles of those different people in the organization have changed as a result of your response to COVID-19?
Yes, I think first of all, I have to explain that before we were faced with this COVID in the Netherlands, we had some experiences in China. So we also have partners in China and Taiwan. And already in December, we learned about the severeness of this disease. So at that moment, a lot of people were talking about, is this just a strong flu, or it's not as bad as we think it is. But we, at that moment in January, February, we were already preparing us about what is happening, what will be what would be the consequences of this virus, and how can we prepare ourselves. At that moment, we already decided that we said, okay, let's find out in our structure what works. How can we support the coaches in an optimal way? How can we support the teams? And what kind of knowledge and experience do we need to guide us through this whole period? And we started to think about materials, protective materials. We started to think about a crisis team. And we started about what kind of people do we need in a crisis team. So, and from, I think, the beginning of March, we were already thinking about what kind of guidelines do teams need when they are faced with corona patients. What kind of protective materials do we need? And how can we communicate in this period in a way that we are very close connected, but can't be together? So we started to work with Hangouts, and we said, okay, in this period, it's important that we have a lot of times meeting or connections with the people who can oversee what's happening. So we said, for example, we will have meetings every week with the coaches. So in 3 regions, to see what's happening in these regions, what they see, how the teams are responding on it, and what can we learn from it as Buurtzorg as a whole. So we build a communication network structure. The crisis team was 24 hours a day available. We had 10 people in our crisis team, specialized nurses. We even had our own epidemiologist. We didn't know that she was an epidemiologist, but she had her promotion on her PhD on the things we really needed. She is leading the domestic part. That's Chantal. Then we had somebody who said who should be responsible for the distribution of materials. We said we are going to build our own distribution center, because at that moment already, the government and the authorities who were in the lead of the policy of what to do said, we don't need masks. If you stay away 1.5 meters from the patient, even if they have corona, you don't need protective materials. So that became the guideline. And this guideline was based on scarcity, not on safety. So we said we will build on safety, and we will find ways to have our own materials. But the whole idea was already beginning of March. We were preparing this, and we said, okay, we will follow what we see in different regions in the country, and we will ask our teams how they feel about it and what they need. And we will follow the needs of the teams, and the teams will be closely connected with the patients. So if we listen to the teams, we also know what patients need and want. So that's where we build on from the start. I remember in the beginning, and somewhere in March, I gave an interview on because there was a lot of people said this is the time to show leadership, and we now have to build a command structure so that the top level of all the organization should show to their workers that they are strong leaders. And I gave an interview about it, said, no, this is the time that we have to listen and to be sensitive for what's happening in our country. We never faced this. This is the first time in our life that we faced such a crisis. So we have to understand what's really happening, and we have to understand how it affects our daily life and how we can prepare and support our nurses as good as possible to deal with it. And so there was already a very different position we took on protection, on leadership, on communication. So we said we really need to be flexible, because what we saw was in Holland, it started in the south, and that was because people celebrated the carnival, and there were too many people together where the virus could easily spread. So we learned from the south, and then it went up to the middle and the north. And in this period, we had a lot of discussions about what are the right things to do. So we were just step by step following what the authorities were saying. Every week there was a press conference, and at the same time we were having this crisis team every afternoon, every day. We were sitting together from 2:30 to 3:30 and discussing, okay, what's our direction, what's our policy, how can we support people, how can we already think up front about what's going to happen. An example, for example, we saw the problems in the hospitals in all these countries, that is ICs, intensive care units, were under pressure. So we said, why shouldn't we develop a hospital at home program for COVID? So we talked with specialists, lung specialists, and we said, if we can keep people at home, for example, people who were already 80 plus, the idea was, should you bring them to the IC, or should you keep them at home? So we said, let's make a program that we are able, with the best possible materials and support, to keep people at home. Let's think about corona routers, so that we have special nurses doing the corona patients. What do we need for doing that? Let's create a corona care path. So let's describe what kind of symptoms, what kind of problems we will see with corona patients, and how can we prepare ourselves for supporting that? What kind of knowledge do we need? What kind of materials? So this was an ongoing process, and nobody was in the lead. So we had this team of 10 people, and everybody was bringing in ideas, insights. And this is also the way, every time again, we said, okay, these are the conclusions for today. And we put it on our website. We said, these are the frequently asked questions. This is what everybody needs to know. And every day we had a review. Every day said, okay, if you have other insights because of the developing crisis, then we should put the last information about what we see on this site. But perhaps you want to ask completely other questions, Brendan. So
well, but let me say also to the participants on in the webinar, by all means, start asking your questions now. We're checking it out on the Q&A facility, and just put your questions there, and we'll put them to Jos as they come in. Jos, I'll get going with another one though. Very interesting to hear you talking about some of the assumptions that a self-managed organization like Buurtzorg would have to, in a crisis, all of a sudden become a command and control organization, and that's what was needed. I think it's fair to say in Britain, there has been two parallel trends going on. One in which there has been a lot of command and control action. For example, the rapid and quite impressively rapid establishment of half a dozen emergency hospitals around England, which it's turned out had not been needed. Now, for all I know, it was prudent to build them anyway, just in case they were. On the other hand, it looks as though central government has not listened to what the practitioners at the so-called front line have been saying about what they actually need in order to meet this challenge well, not least the challenge of personal protective equipment, which has been a huge problem in the National Health Service, and an even bigger problem in home care and in nursing homes. Yeah. I know that you've had a similar controversy in the Netherlands. Following it in March, I could see that you were saying a lot about the need for PPE, and that it would be better to produce it at home, better than nothing if necessary. Can you say a bit more about how that discussion has gone and what can be learned from that discussion in terms of the role of the centre, the government, and the practitioners, the professionals themselves? Yeah.
Well, as I said, when we started to think about what do we need, we said we think that if you don't know if you are having the virus, because we know that you can, before you have symptoms, you can already have the virus. The idea that you have, for example, you have 10 patients in the morning, that you can bring it from one place to another. So the idea is that these patterns, which we have in home care and in community healthcare, but also in nursing homes, we said these patterns are very important to understand on how contamination can happen. So we said the thing we can do is, if we don't know if there is a corona case, at least we can protect the patients from our own possibility to contaminate. So we said, and we already saw in many other countries, there has been a lot of research, for example, in South Korea, in Taiwan, in Cuba, that by protecting yourself, the chance that you contaminate somebody else is far less. So, and we also saw that making your own masks is also not so difficult, and is a possibility to use it when you don't have professional made masks. So we said we will try to have masks ourselves, and we will have self-made masks made by our nurses or families of the nurses. At the same moment, the government took a very strong position in not using masks. So they said in the press conferences they had every week, even using these masks can give a kind of how would you call it in English?
False sense of security.
A false sense of security.
Yeah.
So that's what they said. So I said, there is no research on that. So it was just to protect the policy. The policy of the government was based on scarcity. So there was an article in the newspaper last Saturday, which shown that it was terrible at that moment, and I was talking about between the middle or the end of March. The government couldn't buy enough materials, so they had all kind of middle people who were offering millions of caps, but one of the transactions they talked about 5 million caps, but these caps didn't exist. So at the end, the people they were dealing with were not very trustful people. So it was chaos. It was chaos in getting these things. So they said, what I saw was that the policy was built on not having the materials. So, and based on that, they were saying, you don't need them. And if the guideline is that you don't need them, you have enough. So that was the way of thinking. So and I said, it's crazy. I think that if you let people work and if they understand, healthcare workers are very smart people. And if they understand that in their daily work, that they can contaminate the patients, that even patients can contaminate them, and they can contaminate their families, then we are in a kind of a circle of risks, creating risks for the most vulnerable people and for healthcare workers.
I mean, how tragic that healthcare and home care workers and workers in care homes can be put in a position when they're risking their own safety and lives, looking after people, that they can become the people who infect those who they're trying to look after. That's a terrible burden to carry. That
is a terrible burden. And I have an example. One of our nurses knew a colleague in a nursing home. And in this nursing home, in a very short period, almost 30 people died because of the coronavirus. This nurse had also the virus, and she felt so guilty that she thought that she contaminated the people who were living in the nursing home, and she committed suicide.
Oh yes, that's terrible.
This is a terrible case, but we know many cases where nurses know that they have contaminated people, and they feel they are carrying a terrible emotional burden.
Yeah.
So we said this feeling unsafe. There is even a research on that feeling unsafe has an effect on your immune system. If you have stress, because of if you don't have control on your own safety, then you will be in a kind of stressful situation. So we said, what we wanted is to listen to what people need. So if patients feel more safe when somebody is coming in their house with a mouth cap, and when there is a risk because there are symptoms, that they are wearing gloves and that they are wearing a skirt to protect. Yeah. So we said it's better to do too much than too less.
Yeah.
So and that was seen as what you said, Brandon, as false safety, false security.
Yeah.
But we said no. This is what we need. We were our as I said, our epidemiologist Chantal. She was screening all the documents there were in the world on COVID. So she had all the academical researches. So we said we will build our own body of knowledge on it. And we will not only listen to the Dutch government based on this political-based statements. We got a lot of also a lot of response on it from the professionals, healthcare workers, very positive, but also from people in policy positions and authorities, it was not so positive. So they saw it as they are doing their own thing. And even they said in a press conference, the Minister of Health said, because you are having the protective materials, the people who really need it don't have it. So they try to create kind of atmosphere. But I said, we had a strategy that we said, okay, if we buy big amounts, like 1 million caps, then we can create a supply chain, and we can also give it away to colleagues, because we knew that there were a lot of organizations who couldn't get enough materials. And we said, okay, but when we buy these big amounts, then we will share it. So we had at least, I think, 30 different other home care organizations, nursing homes, sharing mouth caps, skirts, hand alcohol, all these kind of things. So we said, okay, if the government doesn't do it, we will do it. Yeah.
The questions are coming in thick and fast now, Jos, from the participants, both on YouTube and here on the Zoom call. And sticking with the personal protective equipment for the moment, one question is, in the distribution of the equipment to your professionals, did the fact that they are in self-managed teams help with that?
Yes, we said we have teams all over the country. So the first thing we said, okay, what's a simple way to distribute? So we just hired some extra people. We have a distribution center, but we increased the capacity. And we said, perhaps first the coaches are the ones who can easily spread it to the teams, because there was a big difference in the needs. So in some places there was an outbreak of corona, and then these teams needed a lot of materials. But there were also places where we didn't had any contamination, and there we needed less. So the idea was, if the coaches can oversee what the teams need, and they will be the regional distributors, then we bring it first to them. So we built 22 places where we had how you call it, stock.
Stock, yeah.
On gloves, mouth caps, and other materials. Then we said, okay, then we can't foresee everything. If there is special needs for people in a certain region, then we will bring it directly from our centralized distribution center to this place. So it can be there in half a day. So Holland is not so big, so and there was not so many traffic. So we said this will be the distribution of the way we will distribute the materials in the first phase. Then at this moment we are in the next phase. So now we said in every region we want to have 4 places where teams can handle it themselves. So there are 4 places in the regions for 40 teams. So 10 teams can get the materials at one place, and they will organize it themselves, how they get it. But as long as we have on all this around 80 places in the country, we have 80 places with stock.
Has this been very expensive to set up, Jos?
No. I think the first, with buying the big amounts, we could do it, but quite a good price. So we said, we will pay it ourselves, and we will see if the health insurance, because in Holland we are paid by the health insurance, if the health insurers are paying us back, but we will pay it upfront. So we said we will buy everything what's needed, and we will have stock and we will, in the meantime, we will see what we need for the longer term. So, because now it's slowing down, so we see that some regions, they almost don't have any contaminations anymore. Some regions have a lot of, so then we can divide it to the places where it's needed.
So it's highly flexible by the sound of it.
Yeah.
Yeah. Okay, moving on from that, you mentioned hospital at home a little earlier, and there are some experiments going on or that some hospital at home services are already offered in Britain. They've been GP led. Mm-hmm. Is that different from the hospital at home service that you are recommending?
Yes, we are working in Holland with what we call the biggest hospital without building. That's a network of specialists, and the specialists can do all kind of e-health consults. So the nurse, when the nurse needs for support, of course, the basic thing in Holland is that there is a very good relationship between the nurse and the GP. So that's always working very well. But we said the nurse is the one who is in these families most of the time, and the doctor is just visiting once in a while. So we said the nurse should be able to have support when it's needed. So we are now doing on some places the small pilots. We say, okay, we have the collaboration with the GP, but when we have COVID patients, it should be very easy to ask an e-consult from a lung specialist. So and we see this as a team on this topic, which is now we are experimenting on it, but we want to increase it with diabetes, with heart failure, with different other diagnoses after the coming weeks, coming months.
Yeah.
So and for example, we are working also with Philips on e-health. So I'm trying to create a platform where different diagnoses, different patient groups, and different specialists can be supported by monitoring, by diagnostic interventions. But it's always based on a very good collaboration with the GP.
Thank you. You mentioned earlier also the importance of the protection, the mouth, the masks, from the point of view of the emotional health of the professionals themselves, of your nurses and other caregivers. Have you found that you've needed to create more space for your team members to share and reflect on their experiences? In other words, to explore the emotional and psychological impact of the extraordinary situation that they're in, as well as for sharing practical experiences. What's happened there?
Yeah, that's very interesting to see what's already there. So what we, for example, I think it was in March that we learned about the impact that the disease had on the emotional and the psychological side for healthcare workers. And we at that moment we were trying to learn from other fields what's happening there. And for example, we learned from the army, from different missions, what they do in crisis, after crisis situations. What is the care after a crisis? So we found programs. We said, okay, we are going to translate them to Buurtzorg. We will put them in an e-health environment or e-learning environment, and we will offer them to the teams. at the same time, one of the nurse specialists in our crisis team, her father was a psychiatrist, and he was also specialized in these kind of topics. So we said, okay, can we think about a program that people can call us or ask us guidance or support, and what kind of support would this be? So we made several programs on how can we support teams when it's needed, and in the communication all the time. From the start, I made my vlogs. So I filmed myself, and I said every week, every few days, as we send messages to the teams, we put it on our web, and we said, think about how you can support each other. So what are ways to support each other? Because the first one you share your experiences with are your colleagues. So what we saw was that colleagues were very strong in supporting each other. So we said, okay, that's what we think is a good thing. So what can we add to it when it's not enough? But build on what's already there. Mm. So we saw that these Hangouts became normal. So all the teams, they were not able to have physical meetings, but they were having Hangouts. So we saw that this became a more and more natural way of communicating. And we said, if we as crisis team and if the coaches to the teams are doing this all the time, then we are very connected with what's happening. Mm. So then we can also see what works and what doesn't work. So we offer things and we translate the questions of teams, because that was another thing, this 24-hour availability of the crisis team. We got a very good view on what kind of topics were in the heads of the nurses. So there were days, there were hundreds of nurses calling on certain topics. Mm. Then we translated it to kind of sometimes a guideline, or sometimes say, okay, this is what we do when we see this. And then you saw an enormous reduction of these phone calls. So then, okay, then we had the blogs on our web. So then we said, okay, this is what's happening now. What do you think about it? And then we got all the responses from the teams. Oh yeah, we're on the right track. We're doing well. So we feel safe. We feel supported. And with every question we have, we get an answer from a very connected person. So because they were colleagues who were in the crisis team. So this process was, I think, happening all the time. And now I forgot your question, Brandon.
No, you didn't forget it, Jos. You answered it.
Okay.
So thanks very much for that. Changing the subject slightly, I'm going back a little bit to the tension between decentralization and centralization that we touched on earlier. The questions come in: what do you think is the role regulation can play to support health and social care providers? I think in general, it's fair to say that health and social care providers and the professionals employed in them often feel that regulation is a double-edged sword for them, not very helpful. What do you think it can do helpfully in a situation like this? If anything.
Yeah, I'm not very good in following regulations, but what I think it's needed is sensitivity for what's happening. So what I see when I just talked about this reflex on command, what you see, it's a one-way communication. And I think what we really need is a kind of a learning culture. So what can we learn from what's happening, and how can you translate it into regulations, which is helping us forward. So my idea was when we will have this coronavirus for the coming years, when it will, the expectations are we will have different waves of where it will have impact and it. So what we need to think about in my thoughts, I thought what can we learn from it and how to handle it in our daily life. How can we support people to be more conscious about the way it can affect our life? So more focus on prevention, for example. So I should say yesterday evening I had a meeting with our former Minister of Health, which supported us in the early years of Buurtzorg.
Yeah.
And she's now the president of an important advisory council for the government. And together with her, I went to Cuba. And Cuba, I think, is a very good example of preventive care, a preventive system. And so we said, we discussed it several times, and we said, okay, how can we perhaps use this crisis to learn better and more about how to deal with prevention? And that's so regulations should follow, in my opinion, the things we learned from this crisis.
And following on from that, the lessons that are emerging for the teams themselves and for you as a whole organization, and you mentioned a bigger focus on prevention. Do you anticipate that the way in which home care is done by Buurtzorg and perhaps by others in the Netherlands will change as a result of this crisis? Will the role of home care, perhaps in the wider health and social care environment, vis-a-vis hospitals, for example, do you see that changing?
Yeah, I think what we saw in the beginning of the crisis, what we saw was that a lot of patients who were usually staying in hospitals, they tried to get them out earlier because of that. The patients who were going into the hospitals, the COVID patients. What we saw that, and this is an example, I think there are many patients who can be supported at home instead of in a hospital. So I think this will get a push. So this is one thing. So hospital at home, I think, will increase the coming years, and that will ask a lot from community care. So community nurses will have a big role in that. So you see that the whole way of communicating and monitoring is changing rapidly. So we said, okay, how can we make e-health programs for different patient groups? And this in line what I just said, with about prevention, I think that nurses will have a much bigger role in preventive interventions. So these three lines: e-health, hospital at home, and prevention. I think there will be three strategic developments which will have a big influence on development of community care.
Yeah, we're certainly seeing in Britain an increasing interest. We're getting regular calls now from NHS and social care organisations who are saying that one of the lessons of this crisis is actually that there needs to be much more strength in home care and a more holistic approach to home care, which of course, working with you to develop Buurtzorg care in Britain, we're hoping to be able to respond very positively to that. And Jos and I have been discussing how we can do that as soon as we can, and we'll have some further news about that shortly. But what we've also seen in Britain, Jos, is and knowing that in Buurtzorg, such an important part of the Buurtzorg approach is to mobilize the assets and strengths within neighborhoods, not just the professionals, but the voluntary people in families, people in voluntary organizations, and so on. In Britain, we've seen a very strong response from many communities, mutual aid groups springing up, and so on. And indeed, to the extent that perhaps that is the first line of defense in a crisis like this, before the professionals themselves. How do you see that self-organization of communities? How does that link up with the Buurtzorg teams in your experience?
Yes, I think we will find new ways in how to support communities. I don't know if I told you before, but we are doing the Cuba projects in Holland.
Yes.
And that is working with informal care and working with networks in the community. And the first thing, in the beginning of March, when we were faced with the start of COVID, we said, okay, what are other ways to build networks? So we said, why shouldn't we use WhatsApp groups, for example? So we asked people to join a WhatsApp group to share their experience. So we saw that a lot of people got isolated, for example, and because they couldn't, with the lockdown, they couldn't leave the houses. So we said, okay, what are other ways to support this? One of the projects we are doing now is that we bought 2,000 tablets, and we said we are going to give them to the people who have the biggest risk of isolation and who have not enough money to buy them themselves. So we said, and we are going to support them, and we're going to invite them to connect with other people. So these tablets are a way of finding out if this can help to communicate with us or with the nurses, but also to be part of a network we can build digitally. So, and nurses responded, and I was thinking how will nurses and teams respond on it? But everybody, this is a fantastic idea. So this is the moment that everybody will use this, because it's very friendly. So we programmed it in a way that it's very user friendly. So my idea is that this will also give a push on the thinking of community nurses in how to mobilize the community on more ways than we used to do. So
due to community, I mean, one of the conversations we have here is that communities don't necessarily have to be mobilized by professionals. They're often mobilizing themselves, and the professionals need to be sensitive to that and not get in the way of it. What's your view on that?
No, I agree completely. I think that we can have a role, a kind of adaptive role, to support what's already happening. But we should be careful by taking over, because you should not professionalize it in a way that it becomes an organization. So I think you should these things which happens in a lot of places, these voluntary networks, they are very vital. And the only thing we can do is to stimulate, to bring knowledge, to share things, and to work together.
In general, I mean, one of the patterns we're seeing here is, on the one hand, a lot of so in Britain, for example, the government's response to the need for more voluntary activity was to set up a national volunteers system. 700, I mean, the capacity's there, 700,000 people applied to do it, but most of them, it seems, have not been mobilized at all. whereas there's a lot of activity at local level which the government has got nothing to do with, but also is not visible apparently to the government. Right. So it's raised a lot of questions about, well, will the response to the lessons of this experience be more centralization and an attempt by governments and organizations to be more centralized, or to be more decentralized, to allow more, to support and enable more autonomy for professionals in self-managed teams. Now, I mean, we can't see into the future, but it does seem that is one of the, and indeed, we can't see into the future because we have to shape the future ourselves. But that would be a characteristic of the post-COVID and current conversation and activity that we'll need to shape the post-COVID environment. I mean, that's clearly the case in health and social care. Would you say that's happening in other parts of society and the economy as well?
Yeah, I think you see, I think some of the reflexes, I call it, the what I see is that the how shall I say it? What I see happening at the ministries, the government, is the want of centralizing things, and I think it's happening always when you feel that it's more efficient, you have more overview, and it's more. It's the reflex of an average manager, I think, to want to have control about things. You don't have control on it, so you should accept that you don't have control. And you should think about what are the ways to build networks, and I'm convinced that decentralized networks will develop themselves, and they will be much stronger when the central government wants to centralize them. Because what we see now is, and I think perhaps Holland is a little bit different than the UK, but not so much. We see a lot of aversion towards this centralization. So people don't like it.
No.
They say, we want our autonomy. We can, for some period, okay, we are in a crisis, we will listen. But at this moment, we already see that a lot of people are standing up and say, okay, no, we understand the problem, we will take our responsibility, but we will do it based on our own insights.
Yeah.
So, and I think that this, I think the government would be wise if they say, okay, we will coordinate some things centrally, but we will leave the organization decentralized. So, but it's, I think it's an interesting period to see what's really going to happen. And and
we can shape it, Jos. I mean, I think what we have to do is help to shape it with many of the allies and wonderful organizations in the communities that are determined that the new normal is not going to be like the old normal.
No, what we saw, and perhaps that's also good to mention, that in the beginning of Buurtzorg, we had a lot of free publicity. And at this moment, we've been in every newspaper with big interviews on our view on the crisis. So, and it was on the front page of the two biggest newspapers in Holland that we saw there. I even mentioned it a mistake. So I said there has been made a mistake in how we anticipated on the crisis. So when it was on the front page, and the next day it was the debate in the parliament, and the political parties were asking, what do you think about these things to the minister? And of course the minister felt offended, but it led to a change of the policy. So what we say is that if you just follow your lines on based on common sense, and you feel that a lot of people are supporting it, then it will develop. So I think that a lot of people now are aware that you can look from different sides to what's happening, from different paradigms, from different ideas. And we try to influence the policy by just sharing how we see the world, and our way of looking at the world is patient driven. So we should always start with putting vulnerable people in the center, and take these nurses seriously. And if you do that, then you see that people feel listened to, and nurses stay healthy. Because that's another thing. We also started to do our own tests. So there were not enough tests. All the time the minister was saying that there are not enough tests. I said, it's crazy. We have so many labs in Holland. So I just called the lab. And I said, can you do tests for us? Yes. How many do you want? I said, all over the country. When can you do it? Within a week. Okay. So I said to all the nurses, I said, if you have symptoms and you want to be tested, it's possible. So just we organize it in a region. We did it in Rotterdam, in other places. We said, okay, 70 people. From the 70 people, 8 or 9 people were positive. The others were not positive. They started to work again after a few days. But because they were thinking, if I have corona, I don't
similar here. Only they weren't being tested. Yeah.
So I said, we need to test. We need to test, trace, and track. So we need to follow these people, and that's another discussion that's going on. That if you really want the coming years that we have a controlled way of dealing with the virus, we need certain conditions, and one of these conditions is that we, whenever people want to be tested, that you're going to test people, and that you're going to learn from it. And so that's what we. That's the other thing we try to do now. Everybody following this, so we said, okay, we should take more initiative ourselves. So the idea, we had discussion about, is there really a scarcity, or is this scarcity created? I said this last thing. We created this scarcity because we started with thinking that if we don't have the things, and we built this policy on not having these things, that we don't need them. So and that created the scarcity. So I said, if you start thinking from the point of safety, and you say, okay, what do we need to keep people safe? Then you will find all the ways you need to have these things. So, okay, that's
fantastic, Jos. One last question, because we've got online, amongst many others, representatives of some of the teams that we've been supporting to work in the Buurtzorg way. And one of them has asked, in what way do you think the roles within the teams will change, or will they change at all in response to what's been learned from this crisis? And if you think that's not a question to answer now, we could perhaps do a written answer to that theme afterwards.
No, but I think that what we've shown is that the teams are very strong, very flexible. That the way they decided to make special Corona teams just happened. So and when you have one example, the others take over. So I would not think about changing roles in teams.
Oh, okay, Jos, it's been fantastic. Thank you so much. We're going to have to. There's loads more questions, lots of discussion online. You've not been able to see it, but I'll share it with you afterwards. Finally, I want to thank everybody for joining us today. I want to thank my team, Rachel and Alison, who've made this webinar possible and been working away in the background to make it possible. I want to thank the European Union, 2C's funding stream, for their support to us in the Transforming Integrated Care in the Community programme. But above all, I want to thank you, Jos, for making time today, and thank everybody at Buurtzorg who are such an inspiration and guide to us. And to all of you online, please join us again in a couple of weeks when our second in this series of webinars will ask the question, what's love got to do with it? And that'll be a conversation with Donna Hall, who many of you will know as the chair of the New Local Government Network and former chief executive of Wigan Council, who has been really advocating strongly in the last few days for a more decentralised approach, along with Cathy Evans, chief executive of Children England, who is a staunch advocate and has been throughout this crisis keeping on about children's rights in the most important way, and Math Potts, who founded Camerados, and if you haven't tried Camerados spoon rooms on a Saturday morning at 11 o'clock as a fantastic way of getting together in this crisis, you really should. Look it up, Math Potts and Camerados. So that'll be on the 20th of May. It'll be, I hope, somewhat more participatory than this, but we wanted, as I said at the outset, to make sure there was plenty of time for you to get your questions to Jos, for us to hear about how Buurtzorg is doing. So we hope to see you then. Jos, go well. All of you, go well. Stay safe. See you soon.
Thank you, brother.